share now, Dr. Anand.
Got it. All right, good evening, guys from LA, and good day, good morning, wherever you are in the world. My name is Neel Anand from Cedar Sinai, and what we thought today is share with you, and thank you, SSF, for letting us share our work over probably now 18 years now of dealing with severe adult deformity, circumferentially MIS without any osteotomy. And hopefully you can see my slides. So I think it's good to know where we are, right? The lay of the land. We did this study with the Adult Deformity Committee from the SRS, and actually all of them got this is the x-ray they got with a history and asked what they would do. As you can see, just 7%.
Neel, you may want to put yourself on full screen because we're seeing your previous slides.
Okay, go back. I thought I am on full screen. All right. Oops. Hold on. I just lost my screen.
Can you get to the bottom to your views?
Hold on, there it is.
Can you?
I don't see my screen anywhere now. Can we just pause share for a second? I don't see my screen anywhere now. Totally lost it.
Yeah, now we lost you completely.
I don't know why it's completely gone.
Do you want to stop share and then share again?
Let me stop share completely. Can I?
Yeah. Yep.
Just get out of it completely? Okay.
Yep.
I'm going to share screen again. There, hold on.
We have your talk as well, Dr. Anand, so we can bring it up and you can control it from here.
I got it. Yeah.
There.
Am I in full screen now?
No, we're not getting it. So let Linda do it from Seattle then.
Just do it. Can you do it and give me control?
You betcha. Megan will pull it up
I
here.
hope you change what you had to change there.
That's good because we could never
Okay,
keep
thanks.
up with
Sorry
you.
about
Neel.
that. I have no idea why. Can I get control now?
On that bottom left, there's a little floating arrow that'll get you going.
Bottom left floating out. There you go. Okay, got it. So anyway, what we are talking about, SRS, we did this, and it's interesting that just 7% said they would do it circumferential MIS. What's more interesting is that you see 23% said they would do hybrid, which essentially was they would do laterals and then do an open posterior osteotomy and open reduction and correction, as we always did. And what's even more interesting is with our colleagues at ISSG, we were able to look at what hybrid is really all about. And it probably is the worst of all elements. You got the lateral complications and the open posterior complications, blood loss, OR time. It's probably not the way to go. And this seemed to be consistent across 2 or 3 studies where hybrid was equal to open surgery in terms of its problems and not. But on the flip side, the argument would be the MIS cases were very mild or moderate. And so when there were severe cases, people moved to hybrid to do the osteotomies to correct them. And that's why I decided to look at purely severe ASD. And we've done many over the years, sort of looked at that and presented a protocol that we could use for severe ASD. I guess as you get older, you get the right to make some sayings here. And this is my first one. Just because it's easy for us, it doesn't mean it's better for the patient. And I think we need to look at what we can do better, right? The other is MIS surgery will be minimally effective if we do not know what you're effecting. I think we have to know what we are doing. And I think these are 2 really pretty strong paradigms I've lived with. The principles don't change. Indications should not change. Just because you do MIS, you don't operate on somebody you otherwise would not have operated. I think that doesn't change. And you treat the patient, not the x-ray. The other principles are basically if you're doing MIS, do the whole thing MIS. If you're doing interbody fusions, interbody is your best place for an MIS work. Maximize lordosis 4, 5, and 5, 1. Study the anatomical corridors, use them, work them. I think it's all anatomy. That's what MIS is about, not a tube. And then ligamentous taxis to achieve the harmonious physiological reconstruction. Just go about how we do that. There are numerous strategies to go about that. And the whole question is, what do you use, when, and how, and in who? Every one of them matter. It's about getting this all together to get it circumferential MIS to treat deformity is what it's all about. And then, and honestly, where are we with this, especially us? we want to present you a protocol where we do it in every single adult spinal deformity patient that is not fused. And even if they're fused, it only matters how many levels are fused, which level is fused, and there's any open disc to access. And we've been doing this without osteotomies now literally on a 17-year journey, turnkey for the last 9 years. So we got 4 amazing surgeons here, all waiting, chomping at the bits to present their cases. So I'm going to introduce each one of them. First is Dr. Alain, who was a resident at Cedars in orthopedics, did our fellowship with Cedars in orthopedics, stayed on to do my super fellowship with me for 6 months, and now is my junior partner. That's Dr. Alyssa Alain. Then is Dr. David Gendelberg, who's my present super fellow, spent 2 years in Seattle at Harborview, was a clinical instructor and attending there, now spending 6 months with me and looking to an academic job on the West Coast, almost signed. Next is Dr. Chris Kong, who's been my partner for 4 years now. Again, did our fellowship at Cedars, did a Bob Hart open deformity fellowship when he was in Oregon and came to us from Vancouver General, his residency program he did in Vancouver. And then last but not the least, we have Dr. Andrew Chung, who's in Scottsdale, Arizona now at the Sonoran Spine Institute, was my immediate past super fellow, and hopefully he's learned enough to go and actually do it in Scottsdale right now. So we'll see how far he's gotten there. So these are all patients. We see them in every shape and size, right? Every one of these have been treated circumferentially MIS by us, and hopefully we can show you that. So how do we go about this? X-rays, obviously, full-length X-rays. Today we have EOS. Look at all the parameters. We measure them all. I think we all do that. Look at coronal parameters, spinopelvic parameters. So we have an idea of what we got and what are we dealing with. But I think what's more important if you're doing MIS besides this, you got to know the coronal shift. What orbit curve is it? Which side is it to? The tilt of 4 or 5 matters. Can you see the pedicles on X-ray? How much is the spondy? How dynamic is it? What's the lateral listhesis? And then rotation becomes really important. But you're not seeing it. You got to understand all that through a tube. So that matters. Degenerative scoliosis is a completely different animal from adult idiopathic, because degenerative, you work the disc, you put your space and it corrects itself. It really lines up very easily. But adult idiopathic, it will not. There's a structural rotation. So it means you need derotation, translation, reduction techniques percutaneously now with a screw rod construct. And you've got to have that in your armamentarium to correct it. Otherwise, you're going to go wrong. So it adds a complete level that you need to understand. And if you start just throwing a screw and rod in here, it's not going to work in adult idiopathic. Then an MRI, obviously, for the obvious reason. But what's important is we stop at the upper normal disc that's available on MRI and X-ray, the first normal parallel disc. More important then is also sequestrated disc fragment. I can't get that through a lateral approach. So if there is a massive sequestrated disc fragment, I'd rather take that out or do a T-lift before attempting the deformity, but you can't address that. Same with a large central disc. Those are only 2 that matter. A large central disc can get worse when you do a lateral approach by pushing disc material inside and creating worse stenosis. So be careful of that. The rest of it, you need to know to work it anatomically, including facet, but you can work it as long as it's open. The most important thing we look on MRI as part of the protocols, how am I approaching it? Every patient's done the lateral position from L1-2 all the way to L5-S1. And the only thing we look for is a vascular bifurcation. Am I approaching it between the bifurcation like an A-lift in the lateral position, or am I going lateral to the aorta? As you'll see, it's a pre-psoas axis between the aorta and the psoas muscle through a natural plane. It's very similar to the ACDF. We go medial to the carotid in the neck almost every day. Feel the carotid, we go down there, find our plane. This is very similar to an ACDF for the lumbar spine. You go lateral to the aorta in front of the psoas by identifying that plane. And just to step back, we've all done thoracoabdominal approaches, at least I can date myself, we've all been there. Honestly, all we've done is take this and convert it to that, make into 3 small incisions, but what you've spared is the external oblique, the internal oblique, the abdominal muscles, and now you're working between the muscles. But essentially, it's the same to make matters simple, right? And so back to the MRI, there's 3-4 clean access between the aorta and the psoas. If you go to 4-5, it's already split. There's the IVC sneaking under the internal iliac, and there's no way I'm going to do my lateral approach lateral to the aorta, 2 millimeters below the IVC is in my plane. So this would be between the bifurcation. I would do an A-lift in the lateral approach. We'll come to that in a minute. So that's all we decide. 5-1 clearly again is in the bifurcation. So like A-lift in the lateral approach. We take this case now. 3-4, 4-5, and 5-1 has a plane lateral to the aorta. I can get in front of the psoas. There's a clean plane there, and I can get in there. I don't have to go in the bifurcation. I can go lateral. So that's what we decide when we get in there on MRI. CT scan threshold extremely low. We look for vacuum discs, look for sclerosis. You know you got a vacuum disc, it'll move, you get height, we'll get motion. And the more important thing I think on CT scan is the fact that a pars defect's important to know how much you're distracting, but the most important osteophytic fusions, well, you got to break that. You don't understand or realize that, you're not going to be able to break that, and your lateral doesn't work. Or actual complete fusions, you cannot do a lateral at that segment that's completely fused. So you got to plan above or below. In fact, we start doing bending films. All that matters for us is it fused or not? The bending film doesn't help one single bit for me today to know what I'm doing in terms of this strategy of MIS protocols, right? And then bone density is really important. Everyone gets it, T-3. I won't do it, defer it, put them on a teriparatide. The only reason is I know they got it before I operate, and then we go on for a year. If it's between 2 and 3, we'll operate and get them on them right away and give it for a year. And this has been a God-saver for the last literally 12 years. It has saved a lot of patients. So bone density, look at your femoral neck. We published the protocol detail. It's been multiple times published. But basically what it is first stage is laterals. Every single lumbar level as needed is treated in the lateral position. Like we said, between the bifurcation, A-lift in the lateral position or lateral to the aorta, where it's a true lateral pre-psoas. We get them up walking that day or next day. We know we now got indirect reduction because their leg pain's gone. Take an x-ray, reassess what we got, and then decide what to do posteriorly. SVA greater than 10 and PILL greater than 40, we've never had a single patient of ours at this level. I cannot get this paper published without that being there. But all these things being true, if you really not do the lateral well, you got the option of doing an osteotomy when you get to the back and correcting what you need to correct. If not, all you need to do is percutaneous translation reduction and get it back. So what are the advantages of staging? Get indirect reduction, you know that. This X-ray has been critical after the first stage. In fact, it's changed our amount of levels we do. It's changed almost every T2 to pelvis today for me to a T10 to pelvis. And we'll talk about that in a minute. But the key is you've got 2 short surgeries of 3 to 4 hours each in a 70, 80-year-old, way better than one long 8-hour surgery. And there's increasing data that operative duration is probably the single most predictor of complications. Look at the single level lumbar greater than 5 hours, 9-fold increase in SSI, 4-fold increase sepsis, 17-fold increase DVT, and 10-fold wound adhesions. This is single level. Let's extrapolate to multiple levels, and I think it starts making sense. So it's a quick video on just 4, 5, 3, 4, and 2, 3, how we approach it. There's the incision. We'll go down the external oblique, basically split with your finger, find the internal oblique, split with your finger the internal oblique. Once you get through that, you get to the transversalis. You put your finger in the transversalis, you pop it into the retroperitoneal space, sweep, sweep, sweep everything off the front of the psoas. And at this point, I'm feeling the aorta in front of the psoas. My finger is on the aorta, just like you do your carotid on the ACDF. My retractor goes over the finger. The vessels are behind me now. And then the next retractor is basically, come on, okay, here we go. And the next retractor is basically going over the psoas. We'll play that one more, come on, here we go, here we go, here we go, here we go. The next retractor is right over the psoas, not retracting the psoas. I think it's really wrong to retract. We don't retract it. Look at the front of the psoas. You're right in front. Use a sponge stick to clean it and basically get your alignment right in front of the psoas. The endoscopic peanut is really useful to look at that pre-psoas plane. And here's the psoas there. There's the front of the psoas. You can literally see everything, what you need to put your probe in, get your alignment, put your wire in, check on X-ray where you are. And that's basically your approach. And then at 5-1, it's an A-lift in the lateral position. So you have a retractor on the left common iliac, one on the bifurcation, and one on the right common iliac. And once exposed, it basically is the same A-lift we do every single day, except it's in the lateral position. So you have to reorient yourself. That's a 5-1 disc. And if we do 5-1, at all the levels, you just move from 5-1 to 4-5, 3-4, 2-3. and keep moving up with these small incisions and do all the levels we need. ALL release, we rarely ever do an ALL release, and you do not need it in a non-fused patient. There are literally only two indications for us. If it's fused 4-to-1, 3-4 skyphotic. If it's fused 3-to-1 and 2-3 skyphotic, great indication for an ALL ACR and correcting it segmentally at that level instead of a PSO. I think that's been basically a protocol, and that's a great indication for that. A quick examples, 64-year-old female, coronal sagittally imbalanced, and you can see a pre-op post first stage, and immediately that T2 to pelvis became a T10 to pelvis. I have no reason. The thoracic spine has unwound itself. I don't need to go to T2, and you'll see this theme consistently now with the staging. That's the coronal again. You see it all lined up, and that's now 3 years out with CT scan showing the fusion. If anyone doesn't doubt it, we do a CT scan 18 months to 2 years on every patient. Even though a physician from Louisiana, same thing again. Stage, corrected, get all your parameters, all done circumferential MIS. Again, no need to go up in the thoracic spine. Here's another 70-degree curve, massive deformity, same protocol, same thing, same alignment. You don't need to go up to the thoracic spine. Give you 10 years. She came for a cervical spine. This I thought would not work. See the long rod I left behind, thinking I would need to extend it. She's done fine all these years, 10. Here's another one, 2008. The astute among you will see the long rod and this pre-sacral screw, which I never use again, and do not use it, please. It worked on her, 2008, 12 years out. Here's she. Actually has some sacroiliac issues now. That's why she came back. Again, look at that rod, never went up. That thoracic spine is not symptomatic. It unwinds itself. New things, we got imaging, robots, DBM screw anchors. This camera has been phenomenal. Every camera I worked with has been the best we've used. It clips onto your retractor. You're able to see right down the tube, and you're operating on a 4K HD screen looking at it. More importantly, my fellow can see what we're doing. I can see the fellow is doing. It's great for teaching the procedure and going through what we're doing more than anything else. And the visibility and magnification is phenomenal. So that's been really useful. Robots have become a big thing for us now in terms of screws. Great example of a case here, fused before actually by John Cobb, T2 to L2 50 years ago, solid fusion, totally collapsed distal spine, had to obviously extend it. With the robot, we were able to plan these screws right around the old hardware without exposing it, didn't touch the fusion mass, everything percutaneous, 2-hour surgery, which otherwise would have been a 5-hour hardware removal, fusion mass exposure. It's a completely game changer, what it's has done for us. And we'll show you some more cases on that. This screw anchor, again, has been very useful in osteopenics. We're able to put a screw anchor in now to control osteopenics and actually get a solid bite into it. And with MIS, that's been the biggest bugaboo, osteoporosis. So the DBM screw anchor, we're able to put now to get your screws augmented 5 times the peak insertion torque, something I'm very excited about. I've done only 2 cases so far, but looking forward to doing more to make that work. So here's the data we've longitudinally continuously published from day one. We're now at 13 years. I want to give you the latest data we got looking just at adult spinal deformity. This is actually in press. 136 patients. They had to have a COB greater than 50 or one of the swab criteria plus greater than 95 SVA, PIL greater than 20 or PT greater than 30. 2-year minimum follow-up, 923 levels fused, 7 levels on average, 83 months. I can see that. And if you look at the pain scores and all the functional scores, all statistically significant across the board, as well as radiologically significant corrections obtained across the board. So both functional and radiological, we're getting the corrections we need in terms of this protocol. Intraoperatively, of all segmental artery, which we're able to control, luckily, but we did have a retrocapsular renal hematoma way back in 2008. We've already published that in terms of, we published urethral injury and the renal injury, a separate thing. These are all the minor complications we've had in the first 30 days, not minor, the first 30 days. But what's interesting, nothing catastrophic. Pulmonary embolism treated with anticoagulants, acute CV anticoagulants, sepsis was from a pneumonia. And this is what I think is the most interesting. And I waited this long to publish it. And I call your attention to this. The PJK rate is 5.1%. PJF is 2.2%, 3 patients. Hardware failures, 3 patients, 2.2%. This is why I waited this long with each one of you saying, this is BS, it cannot happen. I thought it's BS2. We waited this long to look at it. It is here. It's time to talk about it, and I'm happy to discuss it. This to me is the most shocking things we're seeing right now, and we'll discuss a little bit about it. The PJK we are seeing is this. I left a flat back, that's my patient, and they slowly decompensate over time and ultimately land up doing a PSO, nothing like following them. Or take this patient, Parkinson's, 2009, over 10, 11 years, slowly decompensates, gets worse, and we get this PJK over time. Hardware failure, you see some rod fractures and set screw loosening. Every one of these were incidental. Patients already fused, and we found them incidentally till, of course, we got one after we sent the paper who did have a pseudo at 5.1, and we did revise it. So we had one so far. Most of them are otherwise incidental. And so this is what we're seeing. It's fused at 5.1 on CT, but yet there's a rod broken below L5 at S1. And so you're seeing that is incidental, and they seem to go on to heal. We don't want to rush into doing something. This is a normal loosening. That set screw gets loose. And you see that again incidentally on CT or on X-rays. Don't rush to revise it. If they're asymptomatic, that 5.1 goes on to heal. Why is it so low? I have no idea. I can only come up with theories. But I do think that harmonious physiological restoration, no osteotomies, therefore no stress on the rods, robust anterior column support, a smooth sagittal bend, there's no coronal bend, and we don't do any in situ bending. So I think it's really a paradigm shift from how we've done deformity so far. Osteoporosis treated before, UIE is the first parallel normal disc. It's a soft landing from T to L1 because the interbodies are L1 too. And the rods are 5.5 millimeter titanium alloy, every single rod. And I don't know if it's preserving the soft tissue, but maybe. And there's no in situ bending. That's what this protocol has done, and that's where we are. And I think the best is nothing like being up close and personal. You spend time with us to really see what we do. That's my little plug. This is our fellowship. And with that, I'll stop talking and get everybody else to present their cases. And you can see each case as we go along. Maybe we'll discuss right after that. So Alyssa, you want to go?
Anand. Anand Spine Group?
Yeah, that's our group.
What are you treating, by the way?
What am I treating?
I mean, clinically, I mean, I understand the deformity aspect.
Yeah.
But clinically, you're treating
Pain. I won't operate anybody who don't have back pain.
so functionally disabling,
functionally disabled,
lower back
quality of
pain.
life, 6 months on conservative therapy. These guys have done everything for 2 and 3 years. Progressive deformity. Actually, you don't have back pain, I will not treat deformity. They gotta have functionally disabling quality of life back pain. They got radiculopathy, I'll do a decompression or a TLIF, and I've done many of those. And so, yeah, you're right. Thanks for the question. There's really so much I could put in, but go ahead, Alyssa. And then if you have questions,
Hi, everyone. Hi, everyone. I'm Elisa Alayan. I have a pretty interesting case today.
You got control?
I think she froze.
There you go.
There she goes.
Oh, there we go. Oh, much.
No, go back.
I'm back. Go ahead. Okay. Almost. One last one. Okay, I lost the screen. Hello?
Today is one of those days.
Get right back up.
Okay, one more time.
There you go.
Okay, there we go. All right, so this is a 60-year-old female who initially presented to us in July of 2019. She had history of childhood scoliosis, which was not treated in any way, and she did pretty well for her life, but in the past 10 years, she started experiencing that some pain in her back, and also felt that her deformity was progressing significantly. She had no radicular symptoms though, and she's a pretty healthy lady, some history of hypothyroidism, osteopenia, but other than that, nothing major surgically. These are her x-rays on the left-hand side, and I'll talk about it more in detail soon. The physical exam, we could note the truncal shift to the right when she was standing upright. We could also see the left lumbar curve. She was able to walk on her heels and toes. Her motor strength exam was 5 out of 5 bilaterally. And otherwise, she didn't have any significant pathology on her exam. Her scoliosis x-rays showed that her curve on the right thoracic was 71 degrees and left lumbar curve was measuring 55 degrees. Here are her measurements. So you can see on the left-hand side, she is shifted towards the right side. Her pelvis is rotated. And also note that her ribs are pretty much touching her pelvis on that right side. And this was significantly bothering her. Other measurements, SVA was neutral, 35.8 millimeters. PT was 28.9. PI 72, lumbar lordosis 42, so it gave us a PI-LL mismatch of 20. So we did our protocol. We got MRI, CT, a DEXA scan. Of note, her DEXA scan showed that she was severely osteoporotic. So we started her on Tymlos prior to any surgical intervention. Here are some cuts from the MRI just to show you what Dr. Anand talked about in terms of the corridors we'll look at. So on the very bottom right, it's the L5-S1 corridor. You can see the vessels are split, so easy to go in between the vessels. In this case, at L4-5, the vessels were also split. So we actually elected to do an OLIF at L4-5 as well, and I'll show you the post-op x-rays on that. The rest of the cuts show that we have a pretty good pre-psoas corridor to access the disc. Okay, and here are some cuts from the CT scan. I just wanted to show you the significant amount of facet arthropathy she had and what kind of morphology we can even address with our protocol. And here are some fluoro shots from the stage 1 surgery. So on the top left hand,
You froze again, Alyssa.
do you hear me?
Yeah, you're back.
Oh, okay. So we're at the fluoro shots now. Hopefully we didn't miss too much. So you can see the L4-5 and L5-S1 OLIF already. Now we're going to the L3-4 level with our probe kind of pointing there. And once that level is done, we go to L3 level. And there's just an AP shot showing how our trial looks in between the vertebral bodies. And finally, towards the right, I have a shot of all 4 grafts in from stage 1. Okay, and this is an X-ray post stage 1, standing. So she was able to walk and sit in a chair on post-op day 1. She had no radicular symptoms whatsoever. So she did pretty well. And a few days afterwards, we proceeded with doing stage 2, which was T12 to pelvis. And here's the post-stage. I'll give you all the measurements shortly. She did really well again. No ICU stay, no transfusions, discharged home on post-op day 4 after stage 2. So here are her measurements. So you can see her right thoracic curve, which we were measuring about 71 degrees, now is measuring 37.8, and we didn't even surgically correct it. Her lumbar curve from 55, it went down to 30.8. Her SVA remained pretty neutral, like she started with at 35. Her PT, again, remained about the same. And her PI-LL mismatch actually decreased from 20 to 12. So we gave her a bit more lordosis at 61 degrees. Okay, next slide. Let's see. Okay, so she followed up at 6 weeks, doing overall pretty well, but she knew about a leg length discrepancy, which became much more apparent after stage 2 surgery. And we measured
Froze again.
Can you hear me now?
Yeah, go ahead.
Okay. So at 3-month follow-up, we have standing x-rays with her heel lift in. She is standing pretty level, shoulders are level, pelvis is derotated. And she's doing Pilates 2 times per week. She continues to be on Tymlos as we had planned. She's going to be on Tymlos for a year after surgery because she was so osteoporotic to start with. And she followed up at 8 months. I put in the pre-op x-ray here just to show you how much of a correction we achieved. And you can see that her thoracic and lumbar curves look much better now on the coronal. Importantly, look at her rib to pelvis distance. This really lifted her trunk from her pelvis, and she was very happy about that because she was no longer symptomatic in that region. And we had EOS x-rays at this point, so we were able to get full length, again, globally balanced.
I'm not sure if we're near the end, but should we move to the next person since we're having delays with Dr. Alayan?
You want to move to David?
Or if you want to walk through it, Dr. Anand, the last of it.
Yeah, the last bit is just 1 year follow-up. It really was 1 year follow-up on this patient. I think the key with this case is look at how the thoracic spine sort of unwinds itself. And you don't need to do that thoracic curve. Adults don't hurt in the thoracic curve. I think that's another big change. Just doing selective lumbar fusions is probably way better for them. And we're obviously looking at that over the years. Anyway, that's what this case was about. David's got another case, so maybe we'll talk after David's presentation. David, you want to go? And then they're kind of similar in many ways.
Yeah, sure. I'd be happy to. So my name is David Gendelberg. I'm Dr. Anand's current super fellow, and so far it's been a wonderful time. I'll be presenting this 69-year-old female retired singer who's had chronic back pain as well as right lower extremity radiculopathy. Otherwise, she's neuro intact. She has exhausted conservative management and had also been doing Forteo for about 1 year. Do I have control over the slides? I can't seem to control them. If you give me the...
You do. There's a little arrow bottom left will get you
There
started.
we go. So as you can see, she has this significant curve with foraminal stenosis, which isn't that surprising. Here on CT, you see a lot of vacuum discs, as well as degenerative changes. And if you look closer, you could also see that she is auto-fused at the 3-4 level over there. Here on these next few images, you could see it more clearly. So obviously, as Dr. Anand mentioned before, that would be a contraindication to put an interbody at that level. Here, as per our protocol, we also obtain a DEXA scan. I also like to point out over here that we're supposed to take a look at the femoral neck density as opposed to the spine density, and you can see the discrepancy between the two. As I mentioned, this patient had already been on Forteo for 1 year. Just as a side note, Forteo management does not influence the DEXA score, but it increases the quality of the bone. So that's something to take note of whenever you're treating a patient with Forteo. You're basically replacing the bone with stronger bone. And so We started out with our interbodies for stage 1. We started out with our O-lifts at L1, L2, L2, L3, and L4, L5, again, L3, L4 fused. Here you can see how we are preparing the disc space, gradually increasing the space with the sizers. And we've managed to generate a pretty good amount of space in that level. Here we're continuing to prepare the levels, and you could really see how the curve is, even intra-op, you could see improvements in the alignment. And then for the last part, we actually do an oblique lateral A-lift. And as Dr. Anand mentioned earlier, it's a true A-lift. You're coming from the front. You need to reorient yourself, but it's an A-lift in the lateral position. And so here we're preparing the disc space, and you could really see, looking at the X-rays, you wouldn't know that this is necessarily coming from the lateral approach. It's quite nice. And so post stage 1, you could see we've already gotten significant correction. Over here, there isn't really any necessity to go up to the proximal thoracic spine. You could see the correction here on the uprights. You really see how she went from a PI lumbar lordosis mismatch of 51 down to 13. You see that the SVA before the first surgery was significantly positive and has basically corrected itself after just the anterior portion. And so now, 3 days later, we proceeded to do the posterior aspect, which is percutaneous screws, which is really more added fixation, but we're not doing any significant osteotomies or anything of that sort. Most of the correction was done via the interbodies. You can see how that is just placed in there, no in situ bending, as Dr. Anand mentioned before. And for final results, you could see that her alignment has significantly corrected. Her PI lumbar lordosis mismatch is 9 degrees. She is balanced, and I forgot to mention it earlier, but after just the first stage, her symptoms had significantly improved already. And 3 years out, you can see that she has still maintained her correction, and she's happy as a clam. Thank you.
I mean, it's a good time to stop and take questions. Happy to answer anything anyone wants. I'm sure I've had questions all my life at this, and I'm happy to answer it. We got 2 more cases we can present, or may take a short break now, or we can finish the other 2 also, because the last 2 are really where we are today. But go ahead.
What's the usual interval between the anterior and then getting the patient up to make a decision, and then the posterior? Couple days or longer?
Usually it's Monday, Thursday for me. Occasionally I'll do it same day if it's a really healthy patient today, but between 2 and 3 days. Usually 3 days works really well. Monday we do it. Tuesday morning they're definitely up. Wednesday we get the X-ray. Thursday do the posterior. So it's kind of worked well, and that's my OR.
Neel, why do you delay it? Because you're doing all MIS. Why couldn't you do it all at once? Or do you want to see how the patient does if you have to go back and do a decompression or whatever?
Like I said, there were 3 reasons, right? One is we're actually first time able to document indirect reduction. It truly started out for me for that. I really wanted to make sure this thing really works. And it really has. We've only gone back 4 times in anyone to decompress in all these years. So we are able to document indirect reduction. Their pain's gone when they get up and walk. So we got indirect. 2, that X-ray has been phenomenal in changing what I would have done otherwise. I would have done a T2 to pelvis on many of these patients based on parameters we looked at pre-op. And all of a sudden we see this thoracic spine unwind. I think to me, that's been the biggest paradigm shift, at least in my deformity thinking. And it's changed now to T10. And it's taken me a long time to look at that. It's been consistent. And so today we'll only go to the thoracic spine if there's persistent thoracic kyphosis after our first stage. And that's not very common. It unwinds itself. Now they still have significant kyphosis, sure. And then 3, obviously, is the duration. I think we've really neglected duration as a complication factor with these people. and we can do 2 short surgeries of 3 to 4 hours. I really think it's way different than 8 hours in these patients. These are elderly 70, 80-year-olds. So you have all those 3 reasons. We've always staged it. And it's a young, healthy patient. Like I get a 50-year-old, 60-year-old healthy, I'll do it same day. We'll certainly do it same day.
Okay, thanks.
So you want, if you have no other question, let Chris, you want to present your case?
Sure, let's
Okay,
go ahead.
yeah.
I assume everybody can hear me. All right. Okay, so this is our third case. This next case is a 51-year-old female Army veteran. She presented with 20 years of ongoing low back pain. This was associated with right gluteal pain and some right lateral foot numbness, and the sensation that she had to retrovert her pelvis in order to maintain her posture. She tried multiple non-operative management therapies, including a lot of different pain medications, even opioids, facet blocks, and RFAs, which are transiently helpful. So she now felt that her pain was becoming unbearable to the point that she was worried she wouldn't be able to live independently much longer. So grossly examining her in clinic, she appeared to be globally balanced and neurologically intact. I mean, her images here are nowhere near as impressive as some of the patients that have been presented before me. So I'm a little humbled there. But on the staining films, you can appreciate that there's a lumbar degenerative scoliosis. And as you can see, the parameters are all listed here. Most notably, she has a rather flat lumbar spine with a PI-LL mismatch of about 20 degrees. Her CT shows some gas in the disc spaces and no bridging osteophytes of note. These axial cuts demonstrate absence of any pre-existing facet fusions. And this right parasagittal cut from her lumbar MRI, just demonstrating some of the right-sided L5S1 foraminal stenosis. And these axial cuts demonstrate how there are no large central lesions, such as facet cysts or disc extrusions. Her preoperative DEXA scan showed no osteoporosis. So in creating a surgical plan for this patient for circumferential MIS deformity correction, we consider how much additional lordosis we need to achieve, and we compare that to how many levels we can leverage to achieve this. In this case, every one of our lumbar levels appear to be amenable to placement of interbody spacers via the lateral or oblique approaches. And with regards to planning the UIV, we look at the first neutral horizontal level proximal to the Cobb angle, proximal to the deformity. And in this case, it's T12. And we make sure that the disc above T12 is healthy on MRI, which it is in this patient. So we planned for her first stage lateral interbody fusion at L1, 2, all the way down to L4-5 and OLIF at L5S1. And for her second stage, posterior instrumentation from T12 to the pelvis, with posterior lateral fusion only needed at T12 L1 if we were able to get interbodies at all the other levels before. So here's some of the intraoperative fluoro shots during the first stage. As you can see, the L5S1 OLIF was actually the third level done because our vascular surgeon was bouncing between some other rooms. And because we do this all in one position, lateral decubitus allowed us to address other levels first before our exposure surgeon arrived. This is the CT scout taken between stages. You can appreciate some correction of deformity already. This CT was taken because we, in this rendition of our protocol, as it's been evolving, this was around when we started to introduce use of the robot. So we had a thin cut CT after the first stage to do our robotic planning for the second stage. This is the plan that we rendered going into the OR. And intraoperatively, you can see the little beads overlaying the fluoroscopy. So that's what's needed for the robot to register. We use the robot guidance to cannulate, tap, and tap the pedicles. And this is done in a perk fascial manner with a midline skin incision. And then we use that same guide to place the K-wires. Once the K-wires are placed, we take the robot out and we manually place our cannulated screws, which are attached to large reduction towers. So placing the screws by hand allowed us to do an additional safety check with regards to trajectory and make sure we could feel the right amount of haptic feedback, the screws where we expect it to be. Also, by using the robot to place only wires, it allows us to place screws and towers that would otherwise be incompatible with the robot system. So it's basically a vendor agnostic approach to choosing your instrumentation, even if you still want to use the robot for accuracy or planning or whatever else. So on these select shots, you can see how the combined forces of the reduction towers facilitates additional derotation and correction of the deformity. So here's a comparison of the robot plan and the post-op CT scout. As we were still in the midst of making adjustments to our robotic protocol, we made a habit of obtaining immediate post-op CTs to double check the accuracy of our robotic technique. And post-operatively, she did very well. She was discharged home on post-op day 7. She was mobilizing independently, and she reported being pain-free at 3 months post-op. She continues to do well at 6 months post-op. These are her most recent films.
I think we got only 5 minutes. I'm happy to take questions right now because second case also a robot, prior instrumented case, like I showed a little before. And I think that's where the game changer has been for me with the robot. You don't have to take that old hardware out or expose the fusion mass, and you can do it percutaneously. So that's a big added advantage the robot brings. But happy to take questions. There's a lot of questions in the chat. I've tried answering them, but I don't know if anyone's gone through the chats, but there were a couple of questions on the chat I'm happy to take and maybe discuss it too, right? Someone did bring up, do we do any resections of any kind? No, there's not a single resection, not a single facet is resected, not even a grade 0 osteotomy. And I think that's what is the key here. We're doing 0 osteotomies to create any instability and yet able to get the correction with sheer ligamentotaxis. I think that's something we need to start looking at really deeply. And to me, it's a change of paradigm, having done open deformity for years. Hard to stomach, hard to take. We're all ingrained in what we do, but time to talk about it.
Neel, you haven't had any screw cut out in bone when you put those kind of forces on it intraoperatively?
The answer is absolute yes, which is why osteoporosis is a huge thing. I've had disasters when I started off. I will over talk on complications, every screw pulled out. You don't have any control on screw bone interface. It's a great question. So at MIS, you cannot do an osteoporotic, which is why Forteo or Timlos is such a big adjuvant to what we're doing. And it really helps getting that purchase. And then this whole reduction technique now we've got evolved into that we're very familiar with, where you don't put that stress as a graduated stress. Well, that's a great question. The answer is yes. It will pull out, and we've had times the screw pulls out. I sacrifice the screw and use the other screws I got and try to do the best I can. But best is do not do an osteoporotic MIS. It just is the first thing.
Hey, one more question. So great presentations as always, super elegant. Pertinent to that same question of Jack's, how much do you have to assess and understand flexibility? I mean, I saw your CT scans with the axial demonstration of a fused facet, but isn't it very important as you're kind of exploring this concept of the unraveling thoracic spine that we kind of get a gestalt of maybe on lateral bending films, how flexible the spine is actually before we start putting instruments in? Thank you.
Yeah, it's a great question. I think, again, my first answer will be evolved from open deformity concepts we have had, right? Because we're doing laterals, my only interest is, can I move that disc space when I do the lateral? And so if they got air in the disc space, I know it's going to move. As long as the facet is not fused anywhere, the segment is not fused, that segment I can move and dilate up with my lateral procedure. That's all I'm really looking at. So the flexibility we found is really not useful to us by doing bending films. Half of them don't bend. They really don't help at all. And I've got patients like the one that actually Dr. David presented, Gendelberg, on MRI and X-ray. We didn't know it was fused. It was CT scan that showed me 3-4 was completely fused. No bending film would have showed me that. So it's really been a paradigm shift. So the answer is, I'm not looking at flexibility, I'm rather looking at release. Can I release that disc? That's what I'm looking at. And if I can release that disc, I know I can get the height, get the ligament attached as I want, put the spacers in, and let the spine unravel itself. I tell the fellows every day, it's like having a bunch of blocks in a sock and you straighten the sock out. The blocks will line up. It's the best analogy I have, and I think that's what's happening. I hope that answers your question.
Neel, it's Izzy. Great cases, great series, lots of stuff that's evolved over the years, and you've certainly helped lead the way on that. Can you talk about, with the percutaneous approach, whether you've cemented any of the screws or used the fenestrated screws?
Thank you. Great question again. With MIS, as you know, it's so hard to cement and get control. And I've never liked that. I've used fenestrated screws. I know a lot of guys in the company are not going to like it. I don't like the fact we don't have control on that. I've seen cement fly out of those holes, have leakage from it. I literally stop and I don't like it, which is why now I'm liking this anchor. This anchor seems far more attractive for me to get fixation if I need it than do cement in an MIS fashion where I have no control other than X-ray. So it's kind of a scary thought. So I rather not do that. I think the anchor is a better option and hopefully that will work. I'm kind of excited by it. I'll tell you in a few years if it works or not, but great question. And that's why today for me, osteoporotic, forget it. If they're not on Forteo, I won't do it. I actually will not do it MIS rather than do something else. I think you're almost coming to an end. You want to run through that case, Andrew? You can, but go for it. But run it.
Yeah.
We literally ended. I don't think
You guys made it really easy for me. I'm Andrew Chung. I'm Dr. Anand's most recently graduated spine fellow. It's great. I had great opportunity. I had a great time there, particularly all things considered with COVID. So this is a 50-year-old female, wheelchair-bound, T10 paraplegic, following a previous motor vehicle crash about 30 years prior. You can see here that she's had a previous T10 to L2 fusion. And she presented a clinic with a 5-year history of worsening low back pain, sitting imbalance that was significantly interfering with her quality of life. And she'd kind of run through the gamut of conservative treatments and was kind of at her wit's end and was looking for surgical intervention. Interestingly, she's very high functioning paraplegic. She was a dancer and singer who'd actually made appearances in multiple music videos per her. I didn't actually go look, but I believed her. And she was a non-smoker. When you look at our radiographs here, we have AP and lateral. Unfortunately, we don't have full-length lateral films, but you can see here her previous T10 to L2 fusion with Harrington rod instrumentation. And then just distal to that, you can see that she's got an acute kind of degenerative, or at least from what you can see here, an acute scoliosis in the lumbar spine. Additionally, you can see that she has a pretty notable pelvic obliquity. I'm not sure what happened here when my screen went blank. Is that me or? Oh, there we go.
Just run through that, Andrew. Okay, just run through the slides. I think people can see what happened. Basically,
yeah. It went blank. So yeah, so on the lateral, you can see some destructive changes at the L2-3, just distal to the construct. She's got some kind of fluffy marginal osteophytes, if you will. Let me get the next slide here. Just put this in here to show, again, just kind of showing you the changes that we're seeing at the L2-3 level. Almost has this pseudo articulation here, which is very interesting. CT scan really shows the full picture. If you look at the coronal imaging, the far left, you can see again that kind of destructive looking change at L2-3 with that kind of characteristic fluffy kind of marginal osteophytes that you might see in a Charcot spinal arthropathy. Additionally, you can see she's got a pretty robust spinal fusion mass from T10 to L2. And then you can see on the sagittal image there in the middle, again, kind of destructive changes in appearance, kind of consistent with, again, Charcot spinal arthropathy, perhaps infection. And then put these axial slices in here just to kind of illustrate the difficulty that one might have of kind of perhaps percutaneously navigating around, not navigating, but normally this would be done percutaneous with fluoroscopy, and it'd be very difficult to navigate or get screws around both the fusion mass and the construct more proximally. And I think in most people's hands, this would be an open procedure again, as Dr. Anand kind of showed earlier his case. This would be an open procedure, removing the hardware and then re-instrumenting with pedicle screws and rod construct. This is the preoperative plan. Again, you can kind of see here on the axial slices how adeptly you're able to kind of pre-plan your screws. And as long as all goes well during surgery, you've got some very nice screw placement here. Just some fluoroscopic images intraoperatively showing the interbody placement. You can see some nice height restoration at L2-3. You know, a big knock on robotics is that it delays the OR times significantly. And certainly that's something that I've seen in my training. You know, this kind of shows, and you can actually look at the clocks and verify this. This is time from flyover to basically full registration of the robotic software robot to the patient really only takes 7 minutes. And then again, if you guys want to somehow, well, I guess we didn't include the clock times in the slides to the right here, but from basically flyover to full instrumentation, you're looking at, you know, a little under 2 hours if you've got a nice fluid case. So it really didn't delay, or really doesn't delay surgery as much as I thought it would, which was kind of nice to see. You know, that was something that I took away certainly from the fellowship and that experience. Here's some preoperative and postoperative comparative films. You can see, again, nice correction of the acute scoliosis and some correction of that pelvic obliquity. And on the laterals, you can see that we did almost leave her in a little bit less lordosis just so she could sit a little bit better. And this is just kind of showing everything in sequence here from pre-op to planning to post-op.
Just quick, 2 things on this case. If you used a pre-bent computer to bend that rod, this would have been a disaster. She needed less lordosis. She's a sitter. So it kind of helped plan it. And look at the coronal planning and then what you actually need. It's different. You got to plan differently for what you want and not line up where the screws are. That's my thing I've always said. But this was a game changer. The robot significantly, thank you, Izzy, changed what we did. It truly is a game changer. I mean, this was 2 hours, done. I mean, this should have been like a 5-hour operation. I don't, you know, open the whole thing, through the fusion mass, take hardware out. I mean, it's a nightmare. We've all been there. So that's why I kind of showed this case. So robot has its place. Do you need every case? No. But cases like this makes a big change, big difference. Anyway.
Neel and company, that was a great educational hour. No, thank you very much for adding to all of our knowledge base. Izzy, you have any parting comments for Neel?
Absolutely. Neel, keep up the good work. Keep blazing the trail. Keep charging ahead, showing us what's right and wrong. We've known each other for many, many years. What's always impressed me the most is your tenacity at collecting the data, because that's truly what we need. So let's just keep going. And I think you and I both agree what we're doing today is far better than what we did 10 years ago. But 10 years from now, we're going to look back and say, wow, that was barbaric what we were doing. Now's the real thing. So keep advancing, and all those that have trained with Neel, good job. Thank you, guys.
Hey, listen, I just want to say something. The 712 code was not right.